Hi, everybody. Welcome to the Unit 6 recording. This is the unit over cognitive perceptual and altered senses is kind of the first section that we're going to go through. There's some terminology that you need going into this. The first word is sensation, which is the ability to receive and process stimuli through the sensory organs, like, smell for nose, touch for skin, sight for eyes, hearing for ears. Perception then is the ability to experience, recognize, organize, and interpret those sensory stimuli. So that's, our ability to make sense of what we're hearing, what we're smelling, what we're seeing, that our brain is able to process that and make sense to us. And then cognition is the ability to intellectually think. And that goes into memory, judgment, and orientation of that you're in a person, place, or time. So the first thing we're going to go through is vision. Review anatomy and physiology of the eye on your own time. A couple of basic screening tests that we do. These should be reviewed from last semester. So the Snellen chart, that's this chart looking thing here. This helps with testing visual acuity as far as distances. So acuity is like how well a person can see when compared to people at normal levels. So there's a constant number that you'll see, and it'll be like something over something. And so usually the bottom number is going to be 10 or 20. And that just means that's how many feet away from the chart the patient has to be. That's that constant number. They're always 10 feet away. Now the other number represents how far away the average person needs to be in order to see this letter. So typically to see this E, they can be 240 feet away and still see this E. So if you're being tested on this and you can only see the letter E, you have very poor visual acuity, because somebody at 240 feet can still see this E, but you have to be 10 or 20 feet away in order to see it, depending on, what the chart says. And so we start at the top and we go through having a person read each line. Now they are allowed to miss 2 characters per line, because, like this F might be, it might look like a P, the C might look like an O. So we allow for a little room of error, but they'll get to a point where they just can't go on anymore. And so the further they make it down this chart, the better their visual acuity is. Now, if they get to a point where they can see something and it's like 10 over 20, then that means that an average person can see this at 10 feet away, but you have the ability to see it at 20 feet away. So your visual acuity then would be better than 20/20. Okay, sorry for that interruption there. So I was talking about visual acuity. So Snellen's would be like distance acuity. The Jaeger and Rosenbaum, these are used for nearsighted acuity. So these are little cards that usually you have to hold them. There's so much distance from your face and read the card. And it tests like if you need reading glasses or cheaters or something like that, or a subscription or bifocals, or, it tests that. Tonometry, this is testing the pressure of the eye. We're looking for intraocular pressure, which we'll talk about with some diagnostics coming up. Other screenings, the color screening, this is going to be Ishihara's test for color blindness. These are done quite frequently, especially with the DOT physical, so that, your truck drivers and stuff, they have to be able to see color. And so you flip through this book and then they start telling you the numbers they see. So 3, 5, 6, 12. If they can't see a number, then you write it down, and then in the book will tell you like what kind of deficiency they have. And in this one, it's like tracing a line through. You should be able to see that red and orange line. It's normal for one of these to not see anything. If you do see something, then that is suggestive of a color deficiency. And then here's another line that you should be able to trace through here. I have 3 cousins on my dad's side of the family. They're all 3 brothers, and they're all colorblind. They went to the eye doctor once, and they are like, look at that cool picture on the wall. My aunt looks at it, and she's like, there ain't nothing there. I don't know what you're seeing. And here, it was a picture that if you're colorblind, you can see it. So, and then that's how they figured out that all 3 boys are colorblind. And none of them are truck drivers. So there you go. Pen light. So we check for PERLA, right? That the pupils are equal, round, reactive, and to light accommodation. to light and accommodation, sorry. And then ophthalmoscope. This is a tool you can see in this picture here. We can use to visualize that posterior chamber of the eye. This is a pretty cool assessment if you get the chance to do it and learn more about it. You can visualize these blood vessels, look for optic discs. You can also see all kinds of like calcifications and irregularities. You might be able to see like some retinal changes that have happened. So it is a cool kind of test that you can learn how to do. All right, the first condition we're going to talk about is cataracts. Cataracts is caused by the lens, and that lens loses its transparency or becomes opaque, so it's going to have, places where you can't see through it like you're supposed to be able to. It's a change in the anatomy of the lens. So here's a picture comparison. So a healthy lens versus a cataract, it's blurred, the light's not able to pass through it as clearly as it was. There's a couple of different types. You have primary and you have secondary. So primary is due to the natural aging process. Secondary results from something else. Eye steroids or prednisone use can cause cataracts. I have pretty bad allergies, and sometimes they really start affecting my eyes where my vision is very blurry, just all the inflammation and stuff happening. And, every time I need to have a refill of my eye drops, I get that lecture of, if you use these too often, you can develop cataracts very early on. So, it is something to keep in mind. But I'd like to be able to see and drive and stuff like that. So I do have to use them, but I use them accordingly. Congenital cataracts are ones that you are born with. Assessment findings. So what do we hear? We hear that they have decreased near and distance visual acuity. So you're doing your Snell and you're doing that Jaeger or Rosenbaum, and we see deficiencies there. Okay, we can measure that. Reading cheaters are either not helping or they can't see the road signs. Even with their glasses are like, I still can't see it, Problems with glare from sunlight or headlights, especially at night. My dad, he has cataracts, and, he's waiting right now to get them fixed, but headlights, especially at night, are really hard for him because, the light hits those opaque places in the eye and then it just kind of bounces back and forth off of those. So it's really hard to see past them and then recover from that as well. You'll have changes in depth perception. They'll talk about having trouble stepping off of a curb or going down steps. They may have changes in color perception. Colors may be dull. And then the red reflex is lost as the lens clouds from the cataracts. The red reflex is a reddish orange reflection of light from the back of the eye when viewed with an ophthalmoscope. Diagnostics, how do we know a person has cataracts? Usually the pupil has to be dilated, okay? And then they're just going to look with that ophthalmoscope and see if they can see cataracts, some of those opaque spaces in the eye. Treatments for cataracts is we have to wait a certain degree of severity, and then usually it's a surgical treatment. They can, depending on where it is, how severe it is, they can remove sections of cataracts, or they may replace the lens altogether. That could be with a cadaver lens. There's some artificially made lenses now that are available. It just depends on the specifics of what goes into that. So post-op teaching, we want to teach family big time about this. So if you have a husband and wife that come in, we want to teach both of them how to do this. We demonstrate how to put eye drops in. Key things are going to be, we don't want to touch the tip of the applicator to the eye. That'll contaminate that whole bottle of drops. Things that they're going to probably send home, an anti-inflammatory. We want to reduce the amount of inflammation happening in the eye. There is going to be some inflammation because it's been, there's been surgery to it. There's been trauma to it because of the surgery. So we got to keep that inflammation down. And then we also want it to be free of infection. So a prophylactic antibiotic is also usually prescribed. Avoid activities that may raise that intraocular pressure, right? We don't want any tension on these suture lines or anything. So no heavy lifting, avoid straining with bowel movement, no sneezing, coughing, or vomiting if possible. And this is usually for a few weeks, 4 to 6 weeks before the best visual acuity can be achieved. Sometimes we'll have people even sleep with eye protection on so that they don't rub their eyes while they're sleeping. And then should report any of the following: very bad or worsening eye pain, worsening of visual acuity. We expect it to not be perfect right after surgery. So but if it starts getting worse, then that's when we're worried that something is going wrong. If they're having any nausea, vomiting, and then itchiness or redness to the eye. All right, the next diagnosis I'm going to go over is glaucoma. Glaucoma is a group of ocular diseases that results from an increase in intraocular pressure and decreased peripheral vision. So peripheral vision is being able to see to the sides. So you can see in this picture, you can't see to the sides or, above and below. It is the silent thief of vision. This is it leads to irreversible blindness. It is a leading cause of blindness worldwide. It is very slow and it is permanent. There are two main types of glaucoma. You have open angle and angle closure. And so open angle, I got pictures coming up that kind of shows what that looks like. So open angle. Okay, so for glaucoma, we have the two different types, and here's a picture of those two different types. The open angle, this is more of the slower, insidious type. There's not really a structural change. You can see this angle between the iris and the cornea, essentially is what it is still open, but there's an eventual clog that forms where fluid is supposed to drain. Okay, and assessment for that is typically they're going to have bilateral eye involvement for this. It affects peripheral visual acuity over time. If left untreated, will lead to permanent blindness, and people may experience halos around lights. Normal interocular pressure is 12 to 20 millimeters of mercury. The amount of fluid in the eye gets retained with either kind of glaucoma, which increases the interocular pressure. And an increased interocular pressure causes damage to the optic nerve. So, and what we're focused on with glaucoma is how well this fluid can drain from this spot here. And so with closed angle, this type typically tends to be more of an acute situation, more severe. You can see where the angle here of the cornea is very narrowed, okay? And this is usually due to inflammation, infection, trauma. It can be a little bit gradual too as well, or an emergency, suddenly it happens. And you can see where that clog, it's just totally cut off. And so you can see why this would be more damaging. Like this is a slow clogging. This is totally cut off. It is blocked. And so this one may have pain with it as well. It is an actual structure issue that happens. And so we need to relieve this inflammation in order for the fluid to drain again. So treatments for glaucoma, there's a few different drops that we're going to talk about. Really have to focus on with nursing care, like the side effects of drops. So even though we're putting drops in the eye for a localized reaction, we have to understand that there's going to be some systemic absorption and metabolism of this medication. And so to decrease that, that's why we do that lacrimal duct pressure, which is, kind of just on the inside of the nose there. When we put in eye drops, we put a little pressure there, and then that allows the drop to try to stay in the eye, but also recognizing that it could be, absorbed into the systemic system as well. Miotics, these are also called cholinergic agents. They constrict the pupil so that the ciliary muscle is contracted, thus opening that trabecular meshwork. Reduced visual acuity at night, blurred vision 1 to 2 hours after instilling. The sympathic mimetics, these are also called alpha-2 adrenergic agonists. These reduce intraocular pressure by reducing the production of aqueous humor, which is that fluid in the eye, and increasing its absorption. Contraindicated in patients with asthma, COPD, and heart conditions. That's that systemic absorption. Monitor for bradycardia, hypotension, difficulty breathing. Monitor for signs of acute angle closure glaucoma. Beta blockers, it's pretty much the same thing here. This also reduces the IOP by reducing the production of aqueous humor. Again, same contraindications. You guys need to know those. All right, the prostaglandin analog, your Travatan and Lanzoprost. Okay, I am actually running out of time on this recording, so I'll continue this slide on the next one.